All right, are we at time, I guess?
Yep.
Okay. All right. Hey, everybody. Nice to see all of you guys. My name is Emily Hirsch. I'm at the University of South Carolina School of Medicine in Greenville, and I'm here with,
Katrin Tyler. I'm at UC Davis in Sacramento, California.
and we're going to be talking to you guys a little bit about today about sleep and emergency physician scheduling, and possibly kind of some shared ways forward to improve our physician well-being. Neither of us have any conflicts of interest to disclose.
Regrettably.
So, what'd you say?
Regrettably.
Regrettably, right. So at the end of this didactic today, we want you to be able to understand a few things. Number one, we want you to understand some of the limitations about the individual approach to physician well-being and the benefit of doing a systems level approach instead. I'm going to talk a little bit about some of the introduction to sleep science, circadian rhythm, chronobiology as kind of a basis for the further discussion. And then I'm going to turn it over to Dr. Tyler.
And I'm going to talk a little bit about what a fatigue risk management system actually is and how other industries use it and how we in healthcare and specifically in emergency medicine might think about using it too.
Great. So without further ado, as you guys know and are no stranger to, the way it generally works in emergency medicine right now is you are given a schedule, you are expected to work it, you are expected to figure out when you're supposed to sleep, you're expected to be awake and ready to go when you come to work every day. It is all up to your own individual responsibility. And what we found is that as people get burned out over time and fatigued over time, we've started introducing all of these mindfulness tools, resiliency sort of programming, burnout prevention sort of techniques, things like this. And none of these have really made any meaningful moving of the needle in any of these things. Of course, the emergency department is open 24 hours a day, 7 days a week. We see patients at all times of the day and night. The acuity level of these is very high, and we are expected to function at a very, very high level, regardless of the time that the patient shows up, which means really that our own cognitive readiness is actually a safety critical process. And I know Dr. Tyler's going to talk a little bit more about that as well, but we need to really be thinking about the fact that this really matters for the safety of our patients and for our care. So in 2019, the National Academy of Medicine issued one of their very large reports. This one was about clinician burnout. It's several hundred pages long. And I'm not really going to go into this very much, except to say that they had this sort of big graphic that they talked about here, where they talked about all these kind of external sort of aspects of care funneled through the work system factors at your shop, and then your own individual mediating factors. And all of this kind of combines to lead to you having some sort of balance between being burned out and feeling a sense of professional well-being. And in 2018, the American College of Physicians issued a separate kind of paper that basically said that in their opinion, or in their studies, that 80% of burnout was really due to these systems factors rather than the 20% that were due to the individually mediating factors. And yet everything that we're doing to talk about burnout and burnout prevention is related to this 20% of the individually mediating factors. So the truth of the matter is this is just never going to be terribly effective if we're only focusing on the individual factors. We have to start working on this 80%. And so that's what we're going to be really talking to you about today, is where our sleep and our scheduling fits into this 80% part of the problem. So here we go. I'm going to do a very quick primer on circadian rhythms, chronobiology, and sleep science to sort of get you guys ready for the talk about fatigue risk management systems. So you guys are all familiar with the concept of the circadian rhythm. It's kind of this internal body clock that we have that allows us to kind of respond over a 24-hour cycle to basically day versus night. What I did not know before I started doing this work is that it is not a single body clock. We actually have tons of body clocks. In fact, we have them in virtually every single tissue that we have within our bodies. The master clock is located in the brain in the suprachiasmatic nucleus. It does respond to cycles of light and dark, or light and non-light, but the rest of them in the rest of our body generally respond to other things. They may respond to your physical activity level at a certain time of day. They may respond to whether you are fed or in a hungry state at a particular time. They may respond to your body temperature. Some of them respond to pathogenic exposure. But the truth is that all of these are generally synced with one another, even though they're responding to different things, because generally people tend to eat at the same times of day or be active at the same times of day. Generally, all of these peripheral clocks are usually synced up with our master clock. But when we work a night shift, when we go from day to night, not only are we asynchronizing our master clock, but we're now eating at weird times. We're now active at weird times. And so we asynchronize all of these clocks, and they all do it differently because the stimuli that they're responding to are different. So we're actually misaligning all of our clocks, not just turning them off sync, but malaligning them. You don't really need to read this slide. I just mostly want to show you here that we have all of these kind of typical naders or peaks that tend to happen sort of overnight, basically. So these four things all tend to nadir overnight. These four hormones all tend to peak overnight. So know that a lot of the things that we're asynchronizing are actually sort of our hormonal responses to stimuli. And so that's part of the reason why I have all these long-term health effects, because our entire endocrine system seems to get really thrown out of whack. The next thing I want to teach you about briefly is chronotype. If you've ever talked about someone as a early bird or night owl, you're talking about their chronotype. Chronotype is essentially the body's innate preference for when it wants to be awake and when it wants to be asleep. It is sort of related to your circadian rhythm. It's driven strongly by your genetics. It's very hard to turn a night owl into a morning lark, almost impossible to do. It does shift a little bit as we age, so that's the reason why as individuals become older, why they tend to go to bed earlier and wake up earlier and eat dinner earlier and all of that. That's because our chronotype does shift earlier as we age, but it basically stays relatively stable over a lifetime. The basic take-home point here is that if you adapt to your chronotype and you are active when your body wants to be active and you are resting and sleeping when your body wants to be resting and sleeping, you'll have a better time. You'll enjoy your day better. You'll have a better mood. You'll have more energy. You'll function and think better. Life will generally go better for you. And if you are operating on a schedule that's asynchronous with your body's natural chronotype, you'll have a lot of difficulty. And in fact, it turns out that this is also related to a lot of long-term negative health outcomes. So we've talked a little bit about circadian rhythm, light and dark, and your body sort of knows when it basically wants to be awake and asleep, like your chronotype. But there is a second really powerful drive that makes us need to sleep other than the circadian rhythm. And it's called the homeostatic drive for sleep. And the way it works is this. If you have slept a good night's sleep and you're well rested, when you wake up in the morning, you generally should not feel very tired. You generally should feel pretty well rested, right? Like you don't need a lot of sleep. In other words, you have kind of an empty drive for sleep bucket, if you will. And over the course of the day, as you stay awake longer and longer and longer, you will sort of fill this bucket up with basically adenosine, but with this need for you to sleep. And by the time you get to about 16 or so hours of constant wakefulness, you will feel a tremendous need to sleep. And that's normally the time that most of us would go to sleep. If you do go to sleep at about that time, then over the course of the night, your brain will flush out the adenosine, you'll sort of empty out that fatigue bucket, and by the next morning, you'll once again be feeling like you have little drive for sleep. Does that make sense, how that works? Okay. So as I've said before, when we flip into a night shift, we kind of misalign all of our body clocks. And as we do this, like I said earlier, it kind of throws a lot of our endocrine system out of whack, among other things. But it turns out that this really does place us at risk for all kinds of negative adverse health outcomes. It turns out that this is very much implicated in obesity, in metabolic syndrome, in type 2 diabetes, in cardiovascular disease, because metabolic syndrome plays into those other two. Neurodegenerative diseases tend to be related to this. And because of that change in our endocrine system and our immune system actually all ends up being kind of thrown out of whack because of this, which places us at higher risk for infectious diseases. We also end up with more rheumatologic and autoimmune diseases, and we lose our body's innate ability to scour for cancer cells. And so it also places us at higher risk for a whole variety of cancers. So there are a whole bunch of negative long-term health effects from this flipping our schedules around like we do in emergency medicine currently. But all of us in here are emergency physicians, and when I talk about this with emergency medicine physicians, a lot of times they say, okay, but I don't care. I'll sleep when I'm dead. I'll be fine. Don't worry about it. So the next question then comes, well, what about the short term? How do we do in the short term with this? And I would argue we don't do really very well there either. So remember we talked a minute ago about this homeostatic drive for sleep, and it turns out that after we've been persistently awake for about 17 hours, our ability to perform on cognitive and psychomotor testing declines pretty rapidly. And it declines in an identical curve to people who've been drinking blood alcohol or been drinking alcohol and now have a blood alcohol concentration. So after about 17 hours of constant wakefulness, our impairment on this testing is equivalent to someone with a blood alcohol concentration of 0.05%. And after 24 hours of constant wakefulness, we are impaired to the extent of someone equivalent with a blood alcohol concentration that would make us illegal to drive in 50 states in the United States. And the truth is, we would never let somebody who's impaired from alcohol work in our ER, but we have physicians working in our ERs every single day who have been awake for 24 hours, every single day, and they are equivalently impaired. This was a study done in 2022 by a group using a device like an actigraphy device for sleep. It measured sleep over the course of a period of some months, and it overlaid it with the people's work schedules. And this device also would work with an algorithm called the safety algorithm that would give you an hour-by-hour sort of readiness prediction over the course of the next 24 hours. When they overlaid these readiness scores with the individual's work schedules, they found that in about 25 or 23% of the time, people were working with at least an impairment of a blood alcohol concentration equivalent to 0.05%. And in about 10% of the time, they were significantly impaired, equivalent to a blood alcohol level of 0.08%. So this is significant. This is not an insignificant amount of impairment here. This is kind of how these look when you look at these safety algorithm scores. This is from the FAA, so this is not an emergency physician, but I just want to show you how this kind of looks. So this is basically a pilot who's maximally ready on day one. So they're kind of at their normal baseline. They sleep at night. They go to work, or they are awake on day two, also at their maximum level of readiness. They take a nap during this gray bar. They work an overnight duty period. And you can see that they have a significant decrement in their readiness over the course of the night. They come home and they sleep in the morning, and then they get up in the afternoon. This is us on our DOMA, if y'all call it a DOMA. I know that's what we call it. And you can see that this person is significantly less ready than they would normally be on their usual day-by-day level. And then they sleep that night. They get up the next day, so this is now day two after working a night shift, and they're better than they were the afternoon before, but they're still nowhere close to their baseline. And even on day three after their night shift, you can see they're still a little bit better, but they're still nowhere close to their baseline level of readiness. So it turns out that even after several days, we are impaired for quite a few days after working a single night shift. So I just want to point this out. So the truth is, I think our current system fails us on multiple levels, right? It doesn't respect our human biology. It places us at risk for all kinds of long-term health outcomes. But the truth is, it doesn't even really allow us to be ready in the short term either. So here's what I would say. Over time, we develop all these kind of different levels of fatigue, right? We work off cycle with our circadian rhythm, so we get fatigued that way. We stay awake for long periods of time, so we have this sleep deprivation that makes us fatigued. And over time, it just builds up this cumulative level of fatigue. So when a physician comes to you as a wellness person, as I know some of you in here are, and says, I'm exhausted. I just can't do this anymore. My body is worn out. I am exhausted. My body is exhausted. Believe them. It's not because they're getting older. It's not because there's something wrong with them. It's because our system is perfectly designed to do this. Our system is perfectly designed to wear people out after doing this for 10 or 15 or more years. So with that said, I hope that kind of laid the case of why this is a big problem. I'm going to hand it over to Dr. Tyler and let her take it from there.
Thank you. All right, so I'm going to talk a little bit about what fatigue risk management systems look like. But first of all, so how many people traveled across time zones to get here? How many people felt a bit wonky? How many people have a shift this weekend? So I'm due to get back to Sacramento at midnight, East Coast time, tomorrow night, and I'm on call from 5 a.m. So I should be tickety-boo and ready to go. So practicing what I preach. Okay, so fatigue management is really a shared responsibility. And this is sort of a concept that has been widely adopted in other industries, partly through regulatory processes and partly just because they've realized it's a good idea. So other large industries that have a significant safety component and work continuous shifts. So what are some other industries that do that? Obviously, aviation does that. Any other heavy transportation does that. The energy industry is largely operating with a 24/7 thing, so including mining, Oil and petroleum, obviously, run 24/7 schedules. Many of these other industries, when they have an event, it is often a disaster, right? It's a big event, it's a big national event, and so people have paid a lot of attention to that, and so they have done probably, I think, a better job of calculating what their near misses are in comparison to healthcare, where we generally only kill 1 or 2 people at a time, right? This is also from the Federal Aviation Authority advisory circular that was published a few years ago with this very mind-blowing statement that sleep is the only way to reverse sleepiness. Not coffee, not a shower, not any of those things. And, you know, we spend a lot of time in healthcare sort of avoiding this as a sort of a baseline principle. So there's a lot of reasons why healthcare is very different to aviation, but one of the main reasons, one of the similarities, excuse me, is that, you know, they are paying us to think. That's really what we're in the business for. And that's the same thing as what they're paying pilots for. So Jim Holmes, chair of my department, is not allowed to answer this question, but what is the riskiest part of a flight? Well, let me ask you this. What is the riskiest time in our shift? The sign out is bad, but it could be at any time, right? The disaster could come in 5 minutes after you arrive or 5 minutes before your person replacement comes in. A disaster can happen at any time. When is it most likely to happen on a flight?
Landing.
It's close to landing. It's the top of the descent. So actually taking off apparently isn't that bad. Flying at altitude is pretty straightforward. Nothing bad hardly ever happens there. The top of the descent is when they need their full cognitive powers intact. So actually, all of their sleeping on a long-haul flight is arranged around being fully awake for that top of the descent period. So aviation is one of those areas that has figured out that cognitive performance is really a critical, safety-critical process. So other industries generally do it better than emergency medicine or other healthcare industries. I'm very proud of this photo because I took it taking off from Sydney. But this is, really that the emphasis is on this sort of shared responsibility between the responsibilities of the employer or the organization and our personal responsibilities in making sure that we turn up as rested as possible to do our clinical work. So fatigue risk management systems generally involve sort of a bunch of different parameters. They have some policy components, which sort of overlaps a little bit with cultural norms within your healthcare environment. There is a large educational component in terms of, people actually don't grow up knowing how to balance shift work with their other responsibilities. And I'm sure everybody in this room has had at least one argument with a loved one or parent about their expectations about you being available for something that you don't think you can be available to. Just me? Just me? That's just me? I think it's also really important that we consider what our schedule actually looks like. And Jim will know I've been kind of a pain in the neck about making sure that we have a schedule that facilitates people who need, for a period of time, business hour schedules, right? For whatever reason that might be. So, but the overlying principle is really that there's sort of these organizational structures and individual behaviors that contribute to fatigue management. And we've all seen the Swiss cheese model before. We're basically looking, at hazards going through, and you can see that, this one makes it all the way through, and so the loss is not prevented and there is an incident. And for all the other things, you have a barrier of defenses that hopefully block something going through. So we just have a couple of illustrations of what that might look like when you apply it to fatigue. So this is from a series of articles called the Working Time Society Consensus Statements. And there's actually a bunch of journals that publish these kind of articles, and they're all in industrial health or chronobiology, and there's almost nothing in healthcare, but that's a separate issue. So up here we've got a sleep opportunity, and then what your actual sleep obtained was. So, you might have 10 hours to sleep, but you only slept for 6. then you're cranky and you're disruptive and maybe not on your best behavior, and you put in a couple of wrong orders, but they get caught, or maybe not, and then you have a fatigue-related incident. So, you can see that all the way along there's opportunities to actually maybe do better and be safer. So this is a very sort of similar process. You probably can't read it from the back, but here you have sort of overall hazard, and down the side here we have what the predictive processes are, what the proactive processes are, and what the reactive processes are. And so this is your sleep opportunity, this is your actual sleep, this is your behavior, this is your fatigue-related errors. I know everybody in this room has made a fatigue-related error, and then you have a fatigue-related incident. And I think we've all experienced in healthcare that we spend a lot of time investigating incidents and adverse effects and very little time applying good work design principles, rostering practices, and assessing individual fatigue risk. This is also from that same working time group. And again, this is just illustrating that morning shifts, aligns with most of our chronotype. And so even if they're long, up to 12 hours, and you have multiple little breaks, even if you're doing five in a row, people mostly handle those quite well. Conversely, if you are doing night shifts, 5 in a row, 12 hours with no little breaks in the middle of it, people are going to have a much higher risk of having an incident. Again, this is not just healthcare, this is all incidences. And so one of the most basic take-home things from this is that you can put in a bunch of little breaks and you can significantly reduce the risk. So when you are walking to the cafeteria to get a drink or a coffee or breakfast or whatever it is, that's actually a really important time, and we don't even really make space for it in our schedules, right? How many people actually have any kind of break on their shifts? Nobody, right? Nobody has them. So, the big question is, how can we collectively build a model of shared responsibility for fatigue management in healthcare that also will help us minimize burnout in medicine? How do we protect physicians as we age and experience physiologic challenges and other diseases, because that gets more challenging? How do we protect physicians during periods of childbearing or other increased caregiving responsibilities, such as childcare and elder care? And, this actually says emergency medicine is ready for a shift. Just that, we could borrow, as a large healthcare institution, we could borrow some of the other principles that other industries have already used to assess whether or not you're actually ready for work on an individual day. So thank you very much. That's all we have time for. I think we have a minute for questions. Anybody has any?
One observation on that chart with continuous night shifts, like sequential night shifts, I'm kind of surprised that it's a steady increase in error as time goes up, because I almost feel that I'm a nocturnist, and I almost feel like day 2 is the riskiest day because I haven't fully converted and I'm extra tired because I didn't sleep as well during the day. But by the time I'm on night 3 or 4, I'm fully converted, at least my perception that I'm fully converted. So I feel like my error rate would be lower than day 2, but this shows a progressive increase.
Yeah, so firstly, there's very little data from healthcare. This is from, I think from memory, this is from about 80,000 people. But one of the things there is one study from an ICU in France that looked at resident physicians versus attending physicians. And so firstly, the attending physician's average age was 38, so relatively young. And they basically showed this. They also measured what they called cognitive flexibility, which is essentially, do you recognize when you're making a mistake? And the answer is they were more cognitively flexible as the nights progressed and all the other parameters got worse. So we may or may, we don't know, basically, is basically the answer.
That's why my perception could be wrong.
Yes, we don't know. So one of the there's actually a company out of Boston called Circadian that was started by a surgeon many years ago, but healthcare wasn't really interested. So they do a lot of work in heavy industry, and they contract with another company that actually has like this iPad thing. And when you're coming into your shift, it actually some of the DC bus drivers use it apparently. So it's like you have to match the shapes in a certain time. And if you don't match the shape, basically they do it every single day, every single shift. And if you don't match the shapes compared to how you do, and you're at a certain level, they will like pull you into the office and say, you're not driving a school bus today, you're having an admin day. And we have nothing like that in medicine, right? We don't ask people if they've had a good night, have had a good nap before their night shift. We don't do anything. We're just like, you're good to go. There was a question in the back first.
So this is very depressing, thank you. and I say that after been like 3 hours of sleep in the last 48 hours. So my question is, so what do we do? So is there a model, like, because we don't always have, most institutions don't have a sufficient number of faculty. So you have people doing, a variety of shifts. What is the best methodology for that? Is it that, I was thinking about it just now, it's like, should we actually make not everyone a nocturnist for a 2-week block so that you do that, only, like some people would hate that. Or like after you do an overnight, is your next shift better to be a day shift or a night shift? What tricks do we have to decrease the miserableness?
Yeah. Well, I think a couple of things is we have to start with some of the known physiologic events that we know make it more challenging for people. And so we didn't include in this talk, but there's actually pretty good evidence that in general, your chronobiology gets earlier as you get older. So that's why, the joke about people going for the early bird dinners is true, right? Because now those people are up at 5 a.m. So do you have something in your department that helps move the older physicians earlier in the day? Do you have something in your department that protects pregnant physicians and the early childbearing era? And do you have adequate time off for people? And I would say that partly we don't have enough nocturnists because we've come to accept that as being okay, and we don't push back to our institutions and say, no, we actually need more staffing for this. This is not safe. And partly, we can't say that it's not safe because we haven't documented that it's not safe, But we are at time, so thank you.